Hi, I'm Dr. Johann D'Souza. I'm a clinical psychologist and I specialize in treating obsessive compulsive disorder. That's OCD. One type of OCD is called scrupulosity, which is the fear that God is mad at me or that I'm doing something immoral. It's something that's very common among people who are striving to live a pious life and striving to challenge themselves to live according to God's law. Now, the good thing about scrupulosity is we do have a very effective treatment for it, even though they can be a very debilitating disorder that causes people to actually go farther away from their relationship with God because of fear of God. To understand how to treat scrupulosity, we have to understand better how OCD works. So with OCD, we have two things. We have the obsessions and the compulsions. Obsessions are basically unwanted distressing thoughts. The technical definition is a thought, image, or urge. So a thought is words in your head, an image is a picture in your head, an urge is an unsettling feeling. Thought, image, or urge that's unwanted, distressing, repetitive, intrusive, and unrealistic, irrational, or superstitious. That's an obsession. This unwanted thought leads to an increase in anxiety, which is the second step of the OCD cycle. The increase in anxiety leads to a compulsion, the third step. A compulsion is any behavior or ritual, whether it's overt, physical, or a mental ritual, with the purpose of alleviating anxiety, which is the fifth step. So now we have the whole OCD cycle, the obsession, the anxiety increases, the compulsion, and the anxiety decreases. You could say that a step prior to the obsession is a trigger, some reminder, a situation, maybe a memory that gets the obsession going. So then the whole cycle will be trigger, obsession, anxiety goes up, compulsion, anxiety goes down. Now there are different types of obsessions. There's a few basic categories that most obsessions fall into. One of those categories is scrupulosity, as we said. Other categories include contamination concerns, like fear of germs or sticky substances, chemicals, or contaminants. Another category would be harm OCD, which is fear of harming oneself or others or of being harmed. Another is called taboo concerns, because these are things that people don't like to talk about. They're fears of a sexual nature. Fears like a person is going to sexually abuse another person, even to abuse their own children, which they're never actually going to do. OCD is just giving them that fear. Fear that they're a pedophile, for instance. Of course, that would be very distressing for people. And once again, those people are very safe to be around. It's just OCD giving them that irrational fear. There's also a type of OCD related to symmetry, organizing things, arranging things in perfect order. There's another type of OCD called not just right, which means something it doesn't quite feel right, even though it's hard to put it into words. Like the way my shirt is tucked in, or the tightness of my shoelaces, or the way that my hair looks. It's not perfectly symmetrical or even, and it just feels off, and I need to keep adjusting it. So those are some main types of OCD. The reason I bring those up is because if someone is experiencing scrupulosity, they're almost certainly going to be experiencing these other forms of OCD if in fact their scrupulosity is OCD. So it's helpful to pay attention to other possible symptoms to see if this is a manifestation of OCD that you would want professional treatment for. So the compulsions that correspond to those different obsessions, with scrupulosity, the compulsion is going to be seeking reassurance from other people. It's going to be excessively checking, asking that everything's okay, questioning, is this a mortal sin or is this a venial sin? Did I do this okay? Did I do this right? Was this wrong? Are you mad at me? Did I lie to this person? Was I too mean to this person? Of course, going to the confessor repeatedly, excessively, not believing the confessor, asking for confirmation and certainty. those are going to be compulsions related to scrupulosity. In general, any sort of avoidance is a compulsion. If it's a contamination fear, then avoiding touching dirty things, excessive hand washing, of course. If it's a harm-related fear, it's going to be avoiding being around loved ones out of fear of harming them. Or it's going to be not avoiding walking next to the street, or avoiding walking next to high places, things like that. With ordering and arranging, the ordering and arranging itself is the compulsion. If it's a taboo concern, like for example, a fear of being a pedophile, the person's going to avoid being around children, even their own children. Maybe they'll avoid giving a bath to their own children. So you may ask, what is the treatment for OCD and scrupulosity? The treatment is very effective. There is a gold standard treatment. It's therapy-based within cognitive behavior therapy. It's as or more effective than medication, has decades of research support, and it works. And it's very simple, in fact. The treatment is called exposure and response prevention. What that means is the person faces their fears intentionally, deliberately, systematically. They face their fears and they don't give in to the compulsion. So for someone with scrupulosity, this can get tricky because they're afraid of doing something that is sinful. Well, if they're afraid of doing something that is sinful, we cannot ask them to do something sinful as an exposure. That would be immoral. That's why it's very important to seek a therapist who understands your values. That's why I personally practice modern psychology with traditional family values. So we have to think of a way of constructing the exposure so that they face their fears in an effective way, but a way that's not immoral. Here's some ways of doing it. If they have a fear that they committed a mortal sin and their compulsion is to ask for reassurance, we would say, don't ask for reassurance, and we would tell their loved ones not to give them reassurance. And we would tell their spiritual director, their confessor, don't give them reassurance. We would tell the individual, whatever your spiritual director says, your job is to obey and not ask the same question twice. If there's a genuine question, we can clarify it one time, but that's it. We're not going to give you an answer more than once. And then we're going to ask the person to do healthy things that they may be trying to avoid out of fear. For example, if the confessor says that you are in a good state, then we would encourage that person to receive communion, rather than the person scrupulously examining their conscience and avoiding the communion out of fear, even though their confessor said it was okay. It can be helpful to give, in some cases, very specific guidelines to the person so that they know what's a grave sin and what's not. For example, when it comes to temptations against purity, it can be helpful to know that I'll leave the judgment up to the spiritual director, but some people say things like, look, if the temptation was if it was an internal temptation, it was less than a few seconds, then, or even less than a minute sometimes, people vary. I'm not the one who's going to make that call. But that if it's less than a few seconds, we're not going to treat that as a mortal sin. That's a venial sin. So you shouldn't avoid receiving communion for that. Because people can get really excessively attached to asking themselves, well, how long did I think about it? What did I think about it? And it just becomes unhealthy. And the important thing to realize is this is not based on love of God. This is based on fear. This is a psychological disorder that's distancing the person from God. And here it might be helpful to note, what is scrupulosity, what's not scrupulosity? I think you can think about it in three different levels. So from better to worse. So the best thing is to have a sensitive conscience. That means someone has a well-formed conscience to know what is right and what is wrong. And they're very sensitive to avoiding things that are not only sinful, but also imperfections. So things that may be, slightly vain or self-serving, or again, not sins in themselves, but faults against a virtue. So that's called having a sensitive conscience. I think that is one of the goals of the spiritual life. That's a good thing. That's a healthy thing. And then you have people who have basically a deformed conscience where they genuinely don't know where the line is. And so they think that some things are sinful when in fact they're not sinful. So that would be a type of scrupulosity that's just based on a lack of doctrine, and it's not a psychological disorder. Then you have the scrupulosity part of OCD, which is what I've been talking about, which is a psychological disorder. It's not based on a lack of information in general. Again, some specific guidelines can be helpful, but in general, this is actually an emotional disorder that's rooted in an irrational fear, which is why giving a continued clarification is not helpful for the person, because as much as the person seems like what they're seeking is knowledge and clarification, that's actually not what they're seeking. What they're seeking is emotional comfort. And by providing that reassurance, we're just giving them emotional comfort. So that's the type of scrupulosity that we would want to address with treatment. And the way treatment goes is typically in a few stages. The first stage is understanding what the symptoms what the symptoms are that this person is experiencing, rating the severity level. The nice thing about OCD research is it's very well documented, it's very focused, so we have very specific measures to test the severity of OCD. There's a longer one and there's a shorter one that a specialist can use. So we assess the severity of their symptoms and what the symptoms are, and then we do what's called psychoeducation, which is explaining how OCD works, how the treatment works. From there, we build up the exposure hierarchy. The exposure hierarchy is a list of the person's fears and things the person can do to face his fears. And the reason it's called a hierarchy is because we're going to go from easier to harder. So you can take it from a 0 to 10 scale, you can take it from a 0 to 100 scale. The idea is you get some sense of what would be in the easy level, that may be like the 3 to 4 range. Then we get a sense of what will be in the medium level, 5, 6, 7 range. Then what will be in the hard level, 8, 9, 10. Because most people want to practice graduated exposures, meaning going from easier to middle to hard. There's also the option to do flooding, which is when you just start with the hardest level and then everything after that gets easier. Both of them are effective. Maybe flooding can be a little faster, but whatever the client is comfortable with is how we do it. We do the exposures in session, helping the client see how it's done so that they can experience what's called habituation. Habituation is when the fear goes down over time, which happens anytime we willingly face a fear. Anytime we practice something deliberately, we get better at it. And fear is the same. If we intentionally, deliberately face a fear, that fear is going to get lower and lower and lower. We're going to get stronger. That's one of the benefits of exposure and response prevention, or ERP. Another benefit is even if the anxiety doesn't go down, the client gets better at feeling anxiety, at coping with anxiety, at managing it, so that the experience of anxiety isn't so distressing and intolerable to the person. So that's also a secondary effect of ERP. The first is the anxiety goes down. The second is, even if the anxiety doesn't go down, the person gets more comfortable with feeling anxiety. Another thing that happens with ERP is the person realizes what he was afraid of happening is not actually going to happen and doesn't happen. And the only way to realize that is by testing it through experience. So if the person is afraid that God is going to get mad at them and punish them if they don't do all these compulsions and excessively check and seek certainty and avoid all these distant occasions of temptation, then God is going to punish them. And the only way to test that is by doing normal day-to-day actions that are not sinful, but still that OCD is telling them to be careful of, to do those actions and then realize nothing's going to happen if they do it. Now, you could say that it's tricky to test the consequences of this because the ultimate consequence happens after death, which it would be going to hell. So that's something that we cannot test in real life, of course, which is where another form of exposure is very helpful. So far, I've given examples of real-life exposures, technically called in vivo exposures. But there's another type of exposures that's very helpful when we're facing things that we cannot do in real life. And those are called imaginary exposures. With imaginary exposures, the person imagines the worst case scenario. So for example, often with scrupulosity, the worst case scenario is God condemning the person to hell, and then they're in hell for eternity, distant from their family members and loved ones. So we would walk through an imaginary situation, trying to make it as realistic as possible by incorporating as many of the senses as we can, a lot of detail, and just really trying to strike at the core fear, the underlying fear that the patient has. I'll give you an example of this. It can get very dramatic. I'll just warn you ahead of time, but this is how we do it because it's the most effective way to overcome the fear. So the example would be you are living a life of sin and you're acting contrary to the law of God. You're in a state of mortal sin and God is mad at you, and you realize that if you die, you're going to go to hell. And one day you go to bed and you don't wake up. You do die. And you go in front of the judgment seat of God and you see his angry eyes looking at you with condemnation. And he points his finger at you and you feel your heart stop and you're full of dread. And he condemns you to hell. And the demons rise up and drag you down to hell. And you see the angels and saints behind God hiding their faces and crying. And you realize you're never going to see God again. You're never going to be happy again. And you're going to be tortured by Satan for all of eternity. That's an imaginary exposure. I know that was very dramatic. It can be very difficult for people with OCD, with scrupulosity, to hear that. But hearing that exposure in itself is not sinful. I didn't tell the person to do something sinful. We didn't imagine doing something sinful in detail, right? So that's an example of an exposure that would be effective while also respecting their values, which is of the utmost importance. What happens when the person with OCD hears this? The first time, their anxiety spikes. And then we're going to ask them to listen to that story again and again, or recite it themselves again and again and again. I'm going to ask them to rate their fear throughout that. The first time, their fear might go up to an 8 or a 9. They keep going. After about 30 seconds, it'll be down to a 6 or 7. Another 30 seconds go by, it's down to a 5 or 6. Another 30 seconds, it's a 4 or 5. Eventually, what you'll see is the person starts getting bored, distracted, maybe yawns, looks up, asking basically, are we done with this? That's how you know it was successful. If the client is bored of the script, then it's no longer anxiety provoking. And that was a successful exposure. So we started at a 9 and we went down to a 4. And we would want the person to be practicing this at least 15 minutes a day. Of course, as with anything, the more practice, the better. And we're going to notice not only that in-session habituation of the anxiety going down from a 9 to a 4, but over time, the between-session habituation, where in the first session, it peaked at a 9. Now they did it the next day, it peaked at an 8.5. They did it the next day, it peaked at an 8. And they come back a week later, and now it's peaking at a 4, which means it's not really causing much anxiety. And we would proceed through the hierarchy in that way. In that example, if it peaked at a 9, then that's at the top of the towards the top of the hierarchy but we would be going through their hierarchy and just knocking out those fears one by one by one. And what they'll notice is you don't have to go through every single possible fear, because as you get practice with this, the other fears start to go away. The obsessions reduce, the compulsions reduce, the person gets more confident, and the person begins to see that I can apply this strategy to anything, to any fear that I have. And it's going to go away. And you know what? Anxiety isn't really that important anyways. It's okay to feel anxiety. In fact, it kind of gives me an energy boost. In a way, it can be really helpful, actually. And that's when the person is successful, when they are no longer afraid of anxiety, which is what all anxiety disorders have in common, is the fear of anxiety. When the person is no longer afraid of anxiety, they're anti-fragile, and they can live a life of higher functioning and flourishing. So what I would say to people with OCD, like scrupulosity, or people who live with them is, first, just be aware of what your symptoms are and whether it's interfering with your life enough that you think you need professional help. If you do seek professional help, go to a specialist. What many therapists do is they say that they specialize in many things, which of course means they don't specialize in anything. Go to a specialist who specializes in obsessive compulsive disorder, and specifically the treatment for OCD known as exposure and response prevention, because that is the most research supported treatment. It's a specialty treatment. It's going to be rare. Most people don't practice that. Many therapists aren't even aware that it exists. Many therapists are going to be practicing so-called supportive therapy, or psychoanalytic or psychodynamic therapy, or maybe they are practicing CBT, but they're not too familiar with OCD. They don't know the specifics of exposure and response prevention. So I would look for a specialist in OCD who does ERP. And if it is scrupulosity, meaning there's the overlap with your values, with your religious beliefs, then it would be more important to find someone who understands your beliefs, so they're not asking you to do something immoral. It's very unfortunate, and I hate that this is the case, but even among so-called Catholic therapists, there are people who don't know the science and don't know Catholic morality, and they recommend doing things that are immoral. Some decades ago, there was in fact a therapist who practiced something called mortification therapy, in which he recommended that people who have a fear of viewing pornography, that they view pornography as the treatment. And it's possible that would be an effective exposure, but the treatment will be worse than the disease, because it's a grave evil to do that. So making sure that you find someone who supports your values. If it's not scrupulosity, then it may not be necessary to find someone who supports your values. But if it's, for example, taboo fears of a sexual nature, then yeah, you probably are going to want someone who understands Catholic morality, natural law morality, so that they're not asking you to do an exposure that would be immoral in itself. The great thing about OCD is there's a lot of research into it. There's a lot of free resources online. The International OCD Foundation has many resources. That's IOCDF. If you search IOCDF, you'll find it. And they have printed resources. They have community groups that you can join for support. They have groups for family members of people with OCD. They have videos. So there's a lot of free resources. And if that's not enough, if you need that individual accompaniment, then you can see a specialist to go through this. Just know that you don't have to suffer this for the rest of your life. You don't have to do it alone. There is a very effective treatment for it. And the OCD is not your fault. OCD has a strong genetic component. It's genetically related to things that may not seem to be connected with it, such as hair pulling and skin picking and hoarding disorder and vocal tics and motor tics and even body dysmorphia. Those are all genetically related to OCD. So if the person has OCD, if you look into family history, probably you're going to find someone either with those same tendencies or at least with some symptoms of them. OCD was not caused by a trauma or like an abuse or something like that. Maybe there was some stressful event in the life that allowed the OCD to manifest more. But even something like going through puberty and adolescence can be enough to stress the body out to lead to the manifestation of OCD. But it's not your fault that you have OCD. It's not someone else's fault that you have OCD. But there is a great solution to it. So that's OCD in a nutshell. And I thank you for listening.